Well, hello everyone, and welcome to this Parkinson's Academy webinar, the second of 2023. My name is Diga Hastus, and I'm the head of the Parkinson's Academy and the chair for this afternoon. Before we start, I would like to thank our sponsors, AbbVie, in supporting the learning this afternoon. The session will start with Robin Thackrell talking us through the gut bio in Parkinson's. After a short break, Professor Chowdhury will look at continuous dopaminergic stimulation in patients with complex and advanced Parkinson's. We will be taking questions after each session, so please use the Q&A function for this. If you are unable to hear or see the presentations, I suggest you log out and then log back in again. So, without any further delay, let me hand you over to Robin to start this afternoon's session. Robin, over to you.
Thanks very much, Diga. So thank you again for asking me to speak today on sort of gastrointestinal health and the microbiome in Parkinson's disease. This is a fascinating area which is emerging in Parkinson's disease. And the more I've looked into it, the more mind-boggling it becomes. So I hope that it will be I'll be able to kind of shed some light for you, and I'll really welcome any questions at the end of the presentation so that we can discuss things further, or any examples of patients that you might have where you think that their gastrointestinal health is compromised, etc. So that's just my declarations. So this is a very well-known illustration by William Gowers, who illustrated the James Parkinson's essay on the shaking palsy in 1817. And in this diagram, you can see very well, can't you, the motor symptoms of Parkinson's disease. You could almost imagine the shuffling gait, the reduced arm swing, the stooped posture, the hypomimia you can kind of imagine, and perhaps a tremor. But what you can't see is all the non-motor symptoms, particularly, for example, if he had a very fecally loaded gut, which was impairing his medication absorption and making him feel generally rubbish. And I think it's important that as part of our consultations, and I think people are sort of getting this now, is that we really do focus on these non-motor symptoms, particularly the gastrointestinal ones, as it really can impair quality of life of patients. And after all, that's what we're all about. It's maintaining and enhancing patients' quality of life. So I've told you about the gut microbiome. So what actually is the gut microbiome? Well, it's amazing. It's what it is. It's 1 trillion bacteria, viruses, and fungi and eukaryotes, which live in fine balance in everybody's gut. It weighs a staggering 2 kilograms in and of itself. And there is now the Human Microbiome Project, which has reported 3.3 million unique protein encoding genes from those inhabitants of your gut, which is quite amazing when you think that the human genome has just 23,000 of those. So it's way more complex. These communities of bacteria and fungi, etc., are exceptionally complex, and the sheer amount of them living within you is quite staggering if you think about it. It's in fact being described as an organ in its own right, because it has such key impacts on the human body, including defense against pathogens and a big role in immunity, the synthesis of vitamins, storage of fat, and crucially, an influence on behavior. It's now being recognized as part of treatments of depression, schizophrenia, etc. And also, we know that it may well be significantly involved in the evolution of neurodegenerative conditions, particularly Parkinson's disease and dementia. So there's something known as the gut-brain axis in Parkinson's disease. And this is basically a bidirectional communication between the brain and the nervous and endocrine systems. And it's responsible, as I've said, for regulation of immune responses within the gut and brain. And it's significantly influenced by that intestinal microbiome I've described. And we've yet to discover the power of this dialogue, if you like, between gut and brain. And there's lots of research now going into it. And I think manipulation of the microbiome is going to be part and parcel of individualizing care for neurodegenerative conditions. So you'll be aware of the vagus nerve, which is the most direct path between gut and brain. So I've described where it is and how it extends and what it does. And we know that intestinal stimulation can trigger the vagal signaling, and that's a critical component of neuroimmune inflammatory reflex circuits. And so you see the complexity of it and how manipulating the microbiome can then affect things further up towards the brain. And we think that there's a direct conduit by which material from the intestine can then go up to the brain. I'll explain that a little bit more coming up. So there are various disturbances of the gastrointestinal system in Parkinson's disease. And the most common one that I will focus on in a little while is constipation. And we ignore constipation at our peril. 90% of patients experience constipation. It makes them feel rubbish, and they also don't absorb their medications adequately. And so we need to treat that and ask about it. Patients lose weight, and that can sometimes be inexplicable. And they can lose up to 10 to 15% of their body weight during advancing Parkinson's. Gastroparesis, or poor gastric outflow, can also affect the way that medication is handled. And dysfunction in defecation is also a problem that Parkinson's have as the Parkinson's journey advances. But it's known that people with Parkinson's have an increased permeability of their intestine. And this leads to an increase in translocation of bacteria over the intestine, which in turn leads to aggregation and deposition of alpha-synuclein. And the thought is that this travels up the vagus nerve to the brain and leads to oxidative stress and inflammation. And that is the start, we think, of the neurodegenerative process in Parkinson's disease. And these gut-derived inflammatory products further promote the disruption of the blood-brain barrier, which you'll be aware of. And this then facilitates dopaminergic loss within the substantia nigra, which is what you see in the brains of people with Parkinson's disease. And you can also see these aggregates of alpha-synuclein within the enteric nervous system. And indeed, you can find alpha-synuclein on biopsies of the bowel. So it's all about this. We talked about how these microbiota are in very fine balance. And it's when they become imbalanced that problems arise. So we know that within the bowels of people with Parkinson's disease, there are low levels of certain microbiota, such as the Prebiotics, and this reduces the levels of these health-promoting short-chain fatty acids. And this then changes the biosynthesis of thiamine and folate, and that has a negative effect on the nervous system. And there are also the Prebiotic, which is linked with low ghrelin production. And that's been mooted as something that is really vital to protect the dopamine function in the nigrostriatum. And this is invariably low in people with Parkinson's disease, which figures, doesn't it? We know that with active H. pylori and small intestinal bacterial overgrowth patients, they have low lactobacillus and bifidobacterium, and this then in turn leads to reduced absorption and then reduced effectiveness of levodopa. So if you have patients that are seemingly not responding to levodopa, the tendency is just to increase the dose. But actually, when we look closer, about 40% of these patients have a degree of SIBO or H. pylori infection, which is compromising the ability of levodopa to work effectively. And if we treat that, they can then be more ably treated. And we know that bacteria with anti-inflammatory properties listed there can also be at low levels in people with Parkinson's disease, therefore leading to more inflammatory phenomena. So I've mentioned SIBO, small intestinal bacterial overgrowth, and just here to reiterate that recent meta-analysis, which revealed that up to 46% of patients with Parkinson's have a degree of SIBO as diagnosed by breath testing. And this is quite a large meta-analysis. And if you think about your patient population, that's just under half of them. And I bet most people do not test for that. So what could we do for our patients if we did this routinely? And we think that SIBO is triggered by the gastroparetic effects of Parkinson's disease and that slow transit through the GI tract. And we know that then, if you have an intestinal bacterial overgrowth, this triggers an inflammatory response in the mucosa, further increases the permeability, and then increases the mucosal immune system, therefore worsening the expression of alpha-synuclein. Therefore, I think it's really it's really important that we recognize that SIBO could be an entity. We test for it, and then we treat with antibiotics where we need to. And also, there's the use of probiotics and the use of FODMAP diet, which is, I've shown you below what that stands for, but there's dietitians will often prescribe low FODMAP diets for people with SIBO. Sorry, there's lots of acronyms around. So in terms of case histories, I always like to illustrate things with a case. This is a 73-year-old lady who's had Parkinson's disease for 9 years on Madapar, pramipexole, and a number of other medications. She had a fall, as patients with Parkinson's do, and she fractured her wrist and had a Colles fracture. But for the last 2 weeks, she's been needing help with getting out of bed, needing assistance with feeding and walking. She was phoned through to me from the emergency department consultant, a registrar, who said that he felt that she'd had some catastrophic event, and the family had asked for me to be called because I knew her very well. And I just asked for the breakdown of the GCS, just out of curiosity more than anything. And he said that it was E4 M1V2. So if anybody knows about the Glasgow Coma Scale, it's the eyes out of 4, motor out of 6, and the voice response out of 5. So she's moaning, not moving at all, but her eyes are open and she's communicating furiously with her eyes. And so this didn't sit right with me in terms of a catastrophic brain problem, as he thought she had a stroke or a bleed in her brain. So I controversially went and examined her. And this is what I found. Her abdomen was like this. This is not her CT scan, but it would be a rough approximation of what it looked like. She has a megacolon. And the result, the reason for that was that if you look at her medication, she's on Zydol, 200 milligrams modified release, or Tramadol. Tramadol is a challenging medication and is exceptionally constipating, as well as being a bit anticholinergic. So it makes people confused, it makes people constipated, and it's not a good drug to use, particularly as patients get older. This lady had been profoundly constipated. When an endoscopy was done, they found a lot of capsules of carbidopa in her stomach, which had not been absorbed. And she was basically extremely off. So what did we do for this lady? Well, we put a reticotine patch on in the first instance, excuse me, and referred her to our surgical colleagues, and she needed operative management of her extreme constipation. But with the reticotine, she became dopaminergically stimulated and then got better quite quickly. But I think it's a cautionary tale about the profound effect of constipation on some patients. And constipation is very common. It affects 90% or more of our patients at some stage during their Parkinson's journey. And it leads to an increased transit time through the gut. And as I've mentioned before, it leads to unpredictable and erratic absorption of medication. So if we don't get the bowel transit time right, This can cause significant problems in trying to get a good motor response and management of symptoms. And of course, if we leave it to go unchecked, it can lead to worsened gastroparesis, dilatation of the colon, obstruction, and also unpleasant symptoms which reduce quality of life. So why does constipation occur? Well, people with Parkinson's have a generally weaker abdominal musculature, and also they have a slow peristaltic wave, slower than their age-matched controls. And also, interestingly, they've been noted to have a lower water intake from early life with a generally reduced thirst compared to age-matched controls again. And they tend to take less fiber as well. And they have decreased phasic contraction of their bowel, so peristalsis. So how do we treat people in terms of the constipation? Well, I think it's important always to look at the medications that they're taking before adding more. But in terms of their dopaminergic medications, trying to achieve continuous dopaminergic stimulation, trying to decrease their off time generally, and reduce the burden of other medications, such as anticholinergics, for example. The anticholinergic burden is increasingly important in patients as they progress with neurodegeneration, as it can cause lots of problems, falling, worsened constipation, retention of urine, cognitive issues, etc. I always ask patients to increase their fluid intake and try to encourage exercise, and then use a laxative if you need to achieve a soft stool every day or every other day. I typically use macro goals, but sometimes this can exacerbate anorectal dysfunction. But I'd also say that sometimes patients don't drink very much. And if you're then asking them to drink lots of macro goals, it's not going to improve their general quality of life very much. And so we do need to think about the type of laxative that we suggest and tailor it to each patient. So generally, in order to make progress here, we need to manipulate the microbiome. And we can do that in a number of ways, but one way is to use prebiotics or probiotics, as you'll be aware of, and synbiotics. So prebiotics are mostly non-digestible matter like fiber, and these generally stimulate the roughage, if you like, stimulates the growth of lacto and bifidobacteria within the gut. And you'll remember from the H. pylori slide a while ago that that helps with reducing the likelihood of that. And it also increases the level of brain-derived neurotrophic factor, which is implicated in neuroprotection and neurosurvival and plasticity. Probiotics, as you'll be aware of, are live microorganisms which, when administered in adequate amounts, confer benefit on the host. And symbiotics are a combination of those two. So probiotics, the potential in Parkinson's disease, it may be a way of patients altering the composition of the microbiota and therefore reducing that permeability of the intestinal membrane, which therefore reduces the likelihood of bacterial translocation across their gut wall, which therefore reduces alpha-synuclein and reduces neuroinflammation. So that sounds like a good plan. And as I've said before, we know that H. pylori reduces the absorption of levodopa, and we know that bifido and lactobacilli have proven anti-H. pylori effect. So it sounds like we should be trying to major on that. And we know that probiotics increase gut motility because we use them to treat constipation. And lactobacillus accelerates gastric emptying and therefore is helpful in absorption. And it also helps with that whole richness of the microbiota, which helps with stool consistency and reduces constipation. But what probiotic should we recommend? Now, this is a tricky one because you'll see lots of commercially available probiotics that I'm not going to name, but you'll be aware of the milkshake drinks. But generally, these all get denatured in the stomach, and the amount that actually gets into the gut to be useful is very small. King's College have done a trial on Simprove, which is a liquid multi-strain probiotic. And the claim is that this delivers probiotics to the lower gut. And I must admit that I haven't caught up with that trial. Recently, I knew that it was paused, the recruitment was paused in the pandemic, but I think they may well have drawn some more conclusions. But certainly patients that have taken it, that I have, do comment that it has led to some improvements in a whole variety of things. So weight loss in Parkinson's disease is typically multifactorial, although patients can just lose weight inexplicably. But I always say to people with our Parkinson's population who tend to be on the older side, that Parkinson's isn't the only game in town. You can have a new, and I have in clinic diagnosed thyrotoxicosis, lymphoma, cancer. So when we see weight loss, we should go through the rigor of investigations. But the reason that people can lose weight in Parkinson's disease is due to their poor smell, taste, bit of neuropsychiatry, so apathy and depression, maybe nausea, so that they lose their appetite, which may be drug induced or because they're not emptying their stomach adequately. And then sometimes if they increase their energy expenditure through tremor or dyskinesia, and also if they have dysphagia or malabsorption generally from the reasons that we've discussed. So this picture of I think it's a Cinemet tablet, I'm not sure, which has not been absorbed in the stomach, is similar to what was seen at the end of the endoscope of that patient that I told you about. But the lady that I was talking about was much worse. They pulled out quite a number. But gastric emptying reduction, so delayed gastric emptying, occurs in more patients than you would think, and it's typically experienced by delayed on, so people have early morning offs, early morning akinesia, and they may also describe as feeling of bloating, regurgitation, nausea, or just feeling full up. And treatment strategies include using dispersible carbidopa with their first medication of the day, or using it throughout the day if needed. Sometimes using an apomorphine pen first thing in the morning to get them on, to get their gut moving, which will help them with the absorption of future medications. Domperidone is a good prokinetic, and it's the only one really that doesn't influence, is not sort of contraindicated in Parkinson's disease. Things like proculopride do have a role, but are best used with gastroenterological advice. We know that dysfunction of the bowel acutely can increase mortality significantly for Parkinson's patients. They're more prone to sigmoid volvulus, which is a twisting of the sigmoid around the mesenteric axis, which compromises the blood flow and can lead to ischemia of the gut. It has a high mortality. And you'll recognize here, this is not a Parkinson's patient actually, but this is a classic sigmoid volvulus picture. And if you look with the eye of faith, you can kind of see a coffee bean there. But this classic coffee bean shape is what you see on the abdominal plain film in a patient with sigmoid volvulus. Typically, we would go on to CT these patients. And we can either typically try to treat them with endoscopic derotation or decompression using nasogastric tube. And sometimes people need percutaneous endoscopic colostomy. However, these patients tend to not do particularly well with the instrumentation and intervention that happens, and it tends to recur, and it can, as I say, cause morbidity and a higher mortality. So Parkinson's treatments generally can all have GI side effects without fail, and some of them are more likely to than others. You may have recognized that when you start patients, for example, on carbidopa, they can develop diarrhea, which typically goes away if you put them on carbidopa, interestingly. classical methyltransferase inhibitors, entacapone, the lesser used tolcapone, can have diarrhea, bloating, early satiety, and weight loss as side effects. Sometimes people have torrential diarrhea with these medications, and we need to warn them about that prior to starting it. Otherwise, they end up being over-investigated for their diarrhea. And the new ecodonal blocker, picapone, tends to have much less GI disturbance and is therefore preferable in these patients. So in terms of concluding about the gut microbiota and Parkinson's disease, maintaining gut health is really important. And we don't talk about it enough with our patients, if we talk about it at all. We may just about get round to talk about their constipation, but we don't fully cover it. And I'm doing a clinic at the moment, and I haven't focused on this as much as I should do, and I'm giving the talk about it. But we should be looking out and treating for subacute intestinal bacterial overgrowth, and testing for it with breath testing. We should recognize the fact that people are emptying their stomach suboptimally, and this is therefore leading to worsened absorption of medications. We need to recognize that weight loss does happen in Parkinson's disease, but we shouldn't accept that it is Parkinson's disease that is causing the weight loss until we have gone through the diagnostic rigor of ruling out other things that occur, such as cancer. I talked about constipation, and I can't mention it enough. It was education, education, education for Tony Blair. It's constipation, constipation, constipation for me. Probiotics do seem to be very beneficial in the management of this, but we need to be using the correct ones. And ignore gut health at your peril is what I'll leave you with. There are some references. Slides will be available on the website, I think. I've left good time for, I hope, for questions, which I hope there will be. Feel free to ask anything you like. There's no such thing as a silly question if you don't know the answer to it. And you can bet your bottom dollar that there'll be other people that don't know the answer as well. It's been really nice talking to you, and I hope we have a lot of questions.
Thank you very much, Robin. Yes. So constipation, constipation, constipation. We remember nothing else. That's what we'll remember, and we'll make sure that the patients, we assess those patients. So we've had 2 questions so far. So from your first case study, not looking at the gut at all, but was there a reason for the fall? Was it hypertension, echinacea? What was it? Yeah,
it's a good question. I think actually this lady did have a degree of postural hypotension, but in terms of falling in Parkinson's disease, we should always be checking our patients for lying and standing blood pressure, shouldn't we? As a lying for 10 minutes, standing for 1 and 3 minutes. This is an underdiagnosed phenomena. Yes, I think the reason for this lady's fall wasn't so much an overbalancing or freezing of gait, but it was a postural hypotension, which may well have been mediated by some of the other medications that she was on. And just to reiterate my point earlier, tramadol is an awful medication. Try to avoid it in patients generally.
Okay. There's a couple of questions about that SIBO test. So can you talk a little bit more about that breath test? What people ask?
So it's worthwhile. So depending on the gastroenterology department that you work with, they will test there's a 14C breath test, and there are other breath tests that people do. They will have a screening test for SIBO, and it's about working with them to work out which one they do. And then I've actually drawn up a sort of a pathway with gastroenterologists for when we use it and what we use and how we interpret it. And then patients who are suboptimally, I'm convinced they've got Parkinson's disease, for example, and I'm sure about that, as sure as I can be, but they're just not responding to levodopa as I would expect them to. That would be the time that we would move towards doing a breath test and then treating should it be positive.
Excellent. Ali Mackett's asking, what do you think to the brain first versus gut first theory around development of Parkinson's and the different phenotypes and prognosis seen? So, easy.
Yeah, wow. That's a tricky question, probably a whole talk in itself.
Absolutely.
Ask Ray afterwards. Well, no, I think the more that we know about the microbiome, I think, and I'm persuaded. I guess I'm easily persuaded about lots of things, but I'm persuaded by the intestinal permeability, alpha-synuclein aggregation thing, and I think that is likely to be the way that the neurodegenerative process in Parkinson's and other neurodegenerative conditions starts. That goes hand in hand with the Braque hypothesis, etc. But I think we're doing much more. We didn't really realize the microbiome 10 years ago, really, and now we're realizing it, and we're kind of sequencing its genome and all of those things, and we're learning how to manipulate it. We are seeing impacts on a whole heap of disorders, and I think this is probably a ripe area for sort of treatment. That probably didn't answer your question.
He'll come back if you haven't. So Roseanne Murray, do we underuse diet advice compared with prescribing medication, is that question? And should we be able to prescribe foods, including prebiotic in food form and osmotic laxatives, e.g. prunes?
Yeah, it's a good question. So physicians, doctors, clinicians feel that sometimes they need to finish a consultation with a prescription because it sort of closes it neatly. But actually, quite often it's about intervention, isn't it? And I think you're right. I think I give diet advice around the management of constipation all the time about, flax and golden linseed and prunes and those kinds of things, and explain to people why I'm advising that in terms of absorption of medications and gastroparesis and all those kinds of things. But I think we should be able to prescribe it in terms of FODMAP diets and those kinds of things. Dietitians do. But I think giving the patient advice around it so that they can modify their diet themselves. I guess we have to think about patients who are unable to afford these things, which can be more expensive. It would be good to be able to prescribe them, but I think we're a way away from that.
Okay. Karina's asking, is it advisable to use reticotine patch to a patient who is non-compliant with oral levodopa due to mental health issues and suffers from overflow diarrhea?
Goodness, I'd need a bit more information, but well, yes and no. I think if somebody's refusing to take oral medication, it can be very tricky. Sometimes their sort of neuropsychiatric issues are being caused by the fact they're not taking their medications adequately, and sometimes they can be exacerbated by the dopaminergic medications. What we've got to remember is that dopamine agonists can be relatively psychostimulatory and can make things worse. But I think if you're going to get what you're referring to is we need to get the intestine moving relatively well, and using reticotine as a patch may well achieve this, so that they can then we can see if we can get into a steady state of some kind. It's really hard though, because they're probably not going to take any other medications, and I think probably the root of the issue is to sort out the neuropsychiatry and engage with the psychiatrist to try to get the patient in a more mentally stable so that we can intervene with them a bit more easily. But it's very, very difficult, and I've had patients like this before where you're kind of damned if you do and damned if you don't, and it's a very, very tricky thing. But overflow diarrhea in somebody who is not accepting medications is extremely difficult because you can't get the laxative into them. You kind of have to wait for a crisis, and that sounds a challenging approach. But if they're truly refusing and they've got capacity to refuse, and we can't interact, we can't intervene against their wishes, and we don't have a choice. If they will accept a reticotine patch and not take it off, then that would be something that we could use to try and hope that it doesn't overstimulate them and lead to a worsened psychiatric state. But it's a very, very challenging situation, and I would recommend seeking advice from both Parkinson's specialists, but also psychiatrists and even gastroenterologists as well, because things like prochloropride, there's lots of things that can be trialed, but if they won't take it, that's a challenge.
Okay, so another question's come in. Why does changing co-phenyldopa to co-caryldopa or vice versa help with diarrhea when the active drug is the same?
Could say, I don't know, it just does. But I think the reason is that it's the benserazide versus the carbidopa, likely, because the levodopa is unchanged, so it's likely to be the decarboxylase inhibitor, which is causal or contributory to the diarrhea. Because quite often in 60–70% of patients, I'm not sure about anybody else's experience, but it does help, and the loose stool is much better. So I think it's probably the decarboxylase inhibitor.
Okay, so James Woods is asking, what is the mechanism for constipation causing poor levodopa absorption, given it is absorbed in the small bowel? Is it just a sign of more acutely produced gastric motility?
Well, I'd just say, James, it's a traffic jam. So you're not, that peristalsis isn't working, then you're leading to gastroparesis, and generally things are hanging around for longer and not getting to the small bowel adequately. And so therefore you then get, a peristaltic wave, and then everything shifts, it gets absorbed. So you get a bit too much or not enough, but it just leads to erratic absorption. And so I think you basically got a stacking, and if you're not adequately voiding, you then get either colonic dilatation or gastroparesis, and that leads to problems with absorption all the way through the tract.
Okay, so Effie's asking, isn't treating SIBO with antibiotics counterproductive as it kills the friendly bacteria as well as the harmful bacteria?
Yes and no. So it's only counterproductive for a while. But what we're trying to do is reset, and I think it's that resetting and getting rid of the bacterial overgrowth that then allows for us to get back onto an even keel. So it doesn't completely wipe out all the good bacteria. It's not like sort of chemotherapy, but it will deal with the significant overgrowth that you have and allow for a better absorption. And you're only doing it for 2, maybe 4 weeks, depending on the protocols of your local microbiology departments. So it's well worth it.
Excellent. Jazzy has a question. If a PD patient is on a ward and has constipation history, apart from supportive management, can we just prescribe probiotics as long-term or get the dietitian input?
Yeah, and I think that probiotics are still poorly understood and not commonly prescribed, but I think we can be advising the dietitian in terms of that we think that would be positive. We can advise the patient that they should use probiotics and direct them towards the best types to use, and just the ones over the counter are seldom the best ones to use. But once we get more data about this, I think there'll be more of an imperative to prescribe it, because it will have more of an impact in helping absorption of medication and generally improving people's gut health, which will then lead to improved Parkinson's management.
Excellent. Sam Abraham is asking, is there benefit for routine testing of H. pylori for those coming with wearing off symptoms?
Well, I think if you've had a good response to levodopa, and as a result of a natural progression of the Parkinson's journey that you're developing wearing off, it's not necessarily an indicator of SIBO. It might be, but I think it's probably because they we need to be elongating the effects of their levodopa rather than necessarily thinking about that. But I think what I want people to do is to think about, could this be SIBO? Remember, 46% is a big number in that meta-analysis by Lee. And if we think about that, if we've got any doubt about whether they're absorbing adequately or whether they're, then we should be doing a breath test. I don't want to overwhelm the gastroenterology departments of the UK, but I think it is a good way forward.
Excellent. No more questions at the moment, so I will take this opportunity, Robin, to thank you very much, and there's thanks from the delegates as well.